Okay, welcome everyone to today's session. My name is Ryan Smith. I'm a PCN Pharmacist and Director of MORPh. I'm joined today by my colleague Darshan, who I'll introduce you to in one moment. But just before we start, we wanted to get the understanding of what we do as MORPh out of the way, given that we think this could be a really helpful thing for the PCN pharmacists that are joining us today. So sharing the screen right now to our website. We've put the website in the comments box as well. And we're also sharing it on the other platform that we're using today. Ultimately, MORPh is a network of pharmacists who utilize training, support, education that we provide, all completely free of charge. And we've got on-demand resources and live events for you to join throughout the year. So really great resource for PCN pharmacists. We'd love you to go and check the website out and join us. We've got Telegram groups. We've got actually over 5,000 members. So we think it's worthwhile and we hope you do too. Okay, so I'll introduce you to Darshan first. Darshan, I'll let you run through your bio in terms of who you are, what you do, and then I'll talk a little bit more after that.
Absolutely. Massive thank you, Ryan. And a sincere, warm welcome to one and all. My name's Darshan Negandhi, and I'm a PCN Clinical Pharmacist as part of my day job. And as Ryan alluded to, I'm also part of the MORPh family in terms of delivering and moderating sessions as an associate. And it's great pleasure to be on the virtual sofa with you today, Ryan. And hopefully we're going to get some awesome engagement and be able to really get under the skin of what PCN clinical pharmacists do and how anyone who's looking into becoming one, what sort of things it can actually utilize to basically incorporate their journey into primary care.
Yeah, absolutely. The whole piece today, really, we've got 45 minutes to try and lock as much kind of content in as we can, and we'd love you to be engaging in the Q&A. And tell us what it is that you want to know, really. As much as anything else, it's about the discussion and about reflections between the group. We don't have all the answers, but probably between the whole lot of us on here, we've got a fair number of them. So yeah, please feel free to engage in that way. So Darshan, if we briefly touch on it in the first instance, what it was that led you to become a PCN pharmacist. So you yourself joined the PCN world from a community background, that's right?
That's absolutely correct. My background was community pharmacy through and through. I've worked for multiples, for independent pharmacies, and even at the stage of having my own pharmacy as well. But I think what attracted me to come into primary care and when the opportunity arose for a PCN pharmacist was really to have more sort of say in patient health care and also their outcomes, and really flex my clinical knowledge and my expertise that I've learned so much and gathered throughout my university to really utilize that skill set and develop myself in that way. So that was really my attraction. Was that similar to you as well, Ryan?
Yeah, definitely. I actually started life as a medicines optimization pharmacist back in the day when I qualified, and I think it's interesting to look at the sort of trajectory from the traditional meds op pharmacist into a PCN pharmacist and why they're seen as different. I think really it's quite liberating to look at the role of a PCN pharmacist now and the expectation beyond audit. When I got into the game, it was very much an audit business and it was audit heavy. So yeah, I think over a period of time, I sort of dipped in and out of GP work, worked in a meds op team in a period of time, and now find myself in a PCN, of course. And probably the big thing for me in getting into this was looking at that expectation that the policy drew a line under. To say that, you know, in a few years' time, actually, this is the kind of stuff that our pharmacists are going to be doing. So look forward to getting into more of the discussion with that as we go through the call, really. Just a question then, Darshan, how did you find the transition into PCN world? And I've got lots of colleagues, lots of people that I've supported who've made that move. But it would be great to hear it from you firsthand, really, how you found that and what that looked like.
the thing was, at the time when I joined, which was roughly about just over a year ago, last year in March,
Mhm.
uh, it was very much a case of trying to fly a plane while still building it. So the employers of the PCN still really didn't know what it was all about. All they needed to know that at that time they've got funding to employ pharmacists within the PCN realm, and of course as part of the additional roles reimbursement scheme, that has also expanded to other roles and professions to help support as part of an MDT. But I think it's really been an exponential sort of jet fired in terms of my knowledge, my experience, my clinical expertise has really been sharpened up. And those sort of development has been really an eye opener, because otherwise I would have been ill-equipped if I had to start from day one as a PCN clinical pharmacist. It's really much been a journey and trying to, like I said, build this plane whilst we're still flying it.
Yeah.
And is that similar to you as well, sir?
Well, for me, I found the move into PCN pharmacy more of a change of mindset. Um, a nurse in our practice said to me fairly recently, "You pharmacists are great at drawing a line under a problem, but you're not wonderful at following it up." And that actually kind of resonated to a degree, because back in the old meds up days, you'd kind of produce an audit on whatever it was, and you'd flash it by a clinician, and you'd kind of step away from there.
Yeah.
So that comment that you made was a bit of a change of mindset for me.
Yes.
But back way when I took the role, um, that whole sort of theory that actually we can be the starters and the finishers, I think, in terms of what we're doing. I'm just interested to know, I can see some of the comments dropping in, which is great to see. Um, could all of our attendees actually just drop a number in the chat box just to tell us the number of years that they've been in role, because I think that's quite important for us to be able to pitch this at the right level. The whole session is dedicated toward developing that role, and I think that's going to be fairly universal in terms of where we are and what we do. But it would certainly be, wonderful for us to understand exactly what baseline everyone's coming from.
Absolutely.
Just before we do that, Darshan, we might be jumping the gun slightly with this discussion point, but we've got a question in here about the top 3 key priorities for PCN pharmacists. We will pick up on that, because I think part of that is really just that whole heading of, for me, the priority ultimately is adding value to the team. I don't know what your view is, but for me, good looks like adding value, playing a role, integrating well, understanding how we can do more, be more, but actually doing it in the right way, in line with practice need. What are your thoughts in terms of how you would approach adding value to the role? What have you done between day one and now to try and do that, Darshan?
Ryan, this is the question. This is $1 million question, because ultimately, I always ask myself, how am I showing value within my role? How am I showing the benefit to the practice? And of course, I'm still learning and I'm still developing myself in order to meet the needs of the practice and the PCN. So I think for me, adding value is really about, of course, your tasks that you're doing anyway on an ongoing basis. But remember, as pharmacists, we've got a fantastic network across our sectors, and it's important to incorporate and link in with our secondary care colleagues, our community pharmacists, our industry, all sort of sectors that all, as pharmacists and pharmacy professionals, in fact, all have a duty and responsibility towards patient care and patient outcomes. So I think our biggest benefit is that we've got amazing networks, and that we're able to work across sectors effectively in a sort of collaborative way. But what value really means to me is, how can I reduce the burden on our existing GP workforce by contributing towards my skill set and using my expertise in helping towards that. But that needs to be developed on an ongoing basis, and that's the key, to develop sufficiently to meet the needs.
It's actually an interesting one, and I haven't thought about this from your perspective. But actually, when I know a little bit about your role because we're friends and we talk. Um, but the idea of understanding that you are actually managing chronic diseases in a PCN environment now, but you've got quite a focus in terms of what you're managing. That for me would be quite a nice blueprint for a lot of pharmacists out there who are actually trying to put their stamp on their PCN. Can you talk me through the transition from kind of coming in fairly green without that level of experience and practice to where you are today? Just as an overview, I know that it's a hell of an ask to do that, condense a year into 2 minutes, but what were the fundamental changes that you made?
So the fundamental changes was the way I was conducting my work and knowing where my limitations were in my skill set, and being self-motivated to be able to then develop myself using the training packages that is offered in order to meet the needs and demands. Because the GPs and the nurses don't know what I don't know. They think I know everything. Well, give it to the pharmacist, he'll sort it out. But obviously there is limitations. So I think the biggest development within the last year has been my clinical knowledge and implementation of that clinical knowledge to make sound clinical judgment, which is the biggest heavy hitter for all pharmacists working in, or pharmacy teams working in primary care.
Yeah, okay, that's really good to know. We've got some comments back on the amount of time that people have spent in PCN world, practice world. I think the PCN one certainly doesn't stretch back 25 years, but we've actually got a few people who are kind of 25 years plus in practice.
Yes.
Right down to people who've literally just started in the role. So for obvious reasons, I think it's going to be hard to cater for all, but all we can suggest is if you drop the questions in, that's the only chance we've got of answering them, really.
Exactly.
So for me then, to answer one of the questions around 3 key priorities, adding value for me means undoubtedly contributing in terms of medication reviews, structured medication reviews. That's a really obvious one because the policy is there. It tells you that pharmacists are essentially leading on SMRs. How do you make that a tangible thing that you then do and then grow? I think you need to understand the processes and the systems that are in operation around you as a practice. So I came into my role in my PCN and there was no practice pharmacist prior to me coming in. We had a meds opt pharmacist for a little period of time, but we also had a really significant gap in coverage. So I was kind of coming in as a complete extra pair of hands, which is maybe fortunate, but also made it a little bit tricky to understand how exactly I would then fit into that picture when it was a complete picture. Basically, it was a finished picture. So what I did is I really tried to learn a bit more about from healthcare assistant, nurse, GP, prescription team. How are they operating, and where is that interface between either healthcare assistant carrying out bloods, where does it go, where do those readings go, and what happens? In a similar way, we get discharge letters into the practice, we get requests in from patients. The script team would previously send that to GP. So these flows, as I saw them, it was kind of my role to try and helpfully intercept them and understand exactly how we could capture that and then grow the role from there. So where we are now, present day, we've got a team of pharmacists, we've got pharmacy technicians as well, and we're all essentially chipping into this picture of recalls, med reviews, triage, structured med reviews coming off the back of that. And for me, that's been a really nice, tangible step forward, because before we did that, our nurses were completely blocked out when it came to long-term condition management. So what we really saw is 4 to 6 week appointments for diabetes, COPD, asthma. A lot of these patients can actually be dealt with remotely, and I think COVID's certainly accelerated that and helped that. So for me, I would say point 1, 2, and 3 in terms of the most important things are really all wrapped up as how do you add value? How do you make a tangible difference to your environment? And I think that's been key for me.
Yeah, absolutely. I think just to add on to that also, Ryan, I say with obviously with the current pandemic, patients have actually had more access to their GPs for acute conditions, more so than ever before, because it's just a matter of a phone call. So I think that's why in terms of the medicines management and the long-term conditions really need to be done by somebody else, and that's where pharmacists can and pharmacy teams, as with pharmacy technicians, can really make a massive impact on the management, monitoring, and ensuring that the patient's getting the biggest bang for their buck regarding their therapy. So I think dead on what you're saying there.
I think scope is an important thing, and I see in the comments that somebody's asked the question around what are the responsibilities in your role and how did you embed yourself? Part of embedding yourself, I think, is about having that focus around not just process, but which long-term conditions are you going to target? Yes. What do you feel comfortable with? Clearly, it has to be led by your own competency. You can't go for everything if you're not, safe and effective in doing that. So what we did as a PCN, we actually had a collective task list for all of our recalls. Our med reviews became tasks as opposed to appointments, as they were pre the change. That allowed us for the healthcare assistants to actually label those tasks with LTC management and actually list the conditions. So we're able to pick out, almost as a wider team, we could take things out that we were comfortable with. And we could use that as a bit of an education tool as well in many ways. You bounce a task on to a nurse colleague, maybe in a condition that they're familiar with, but you're not. All of a sudden, you're entering dialogue with that person. What did you do with those blood results? Why? What was the interpretation? And that's how you start growing your competency, really, in my view, by engaging with those people around you and understanding how they do things. I'm just keeping an eye on the chat function as well, because we've had a few more comments come in. We've got some feedback here just in terms of, so we've got more numbers in terms of length of practicing time. Just while I'm reviewing this last one, Darshan, competency is a big issue for a lot of people, and rightly so. I've come across a lot of pharmacists in my day-to-day role where I'm supporting people who are maybe suffering as a bit of a mismatch of expectation between their GP or their PCN employer and their own. And at times, it's particularly those people who are just fresh into this, where they've not had the history of working in general practice, and they almost don't know where their own boundaries are. Have you got any advice for that cohort of people who might be stepping into this role?
Absolutely. I mean, there are networks available. In fact, I've got a network with MORPh on Telegram that does just that. It just kind of helps support and give guidance to PCN pharmacists who have joined in or have been PCN pharmacists for some time, because the issue is, well, we don't know what we don't know, and the only way we're going to be able to grow is to be able to grow together. And if you've got a question, you can bet your bottom dollar that someone out there in the same role, in the same capacity, has done it, they've got the t-shirt and is able to show you how. Now, as you're aware, these roles are all funded by the taxpayer, right? So it's important that we share this information, and using the Telegram groups that we've got really helps embed that sort of clinical therapeutics, guidances, new protocols and processes. Why reinvent the wheel? Time is such a precious commodity at the moment, especially when we're trying to catch up with a year's worth of break due to the lockdown. That we can get where we need all the help that we can, and I think it's important for these networks to be utilized appropriately. What do you think about these? What do you think about the networks? Do you think that might be the way forward, Ryan?
Yeah, I agree. For me, competency starts with kind of having that awareness and self-awareness that you actually need to be looking at something in the first instance. If it's easy not to think about competency unless you kind of do have a bit of a reflective moment around that sort of thing, because it's very easy to get caught up in the here and now. The GPHC and other organizations have got tools that allow us to support our competency and make a statement of competency. So whether it be a framework or a statement of competency, I think that's a good starting block for me. The thing I would worry about potentially is, for a lot of the pharmacists coming in, is that the expectations placed upon them and the pressures placed upon them could be quite a dangerous one in many ways. Yes. So yeah, I think competency is really up there in terms of the thing that needs to be front of mind, and really a conversation that you should be having with clinical supervisor, ensuring that you're comfortable with everything that you're doing.
Absolutely. Absolutely.
We've just got a handful of comments that I think it's worth running through the questions. First of all, just a comment actually. Just somebody talking about actually the need for showcasing the value of pharmacists and the way that we do this. Given that these roles are funded at the moment, but they may not be funded forever, I think that's a really good point, really. How do we showcase that role? How do we showcase that work? We want to be getting to a stage where our GPs just couldn't do without us, right? That's kind of what we're aiming for. Yeah. So I think everything that we've discussed so far around value and really demonstrating that value, being very focused with targets and what you're going to go for, and how you fit as part of that system, I think that all reinforces that. Further question, I'll hand this one over to you, Darshan. Not because it's a difficult one, just because I'm interested to get your take on it. What is the difference between an SMR and a normal med review? I'm going to say normal. I'm not sure. I've never had a normal med review. I don't know which patients they're reviewing, but go for it.
So fundamentally, a structured medication review is just that. It's a structured, holistic, personalized review of a patient's, of all the patient's therapy. It's not just a particular condition or a particular class of drugs. It needs to be a holistic review. And this is where the skill set of communication skills, being able to impart on your health coaching to ensure why the patient is doing what they're doing and what are the lifestyle, the ideas, concerns, expectations, and beliefs of the patient that impact on their ability to take that therapy. Whereas a medication review essentially is they've ordered some medication, they're due for a medication review, they're taking everything all right, it's fine, just carry on, and there's no issues, there's no bloods outstanding. But the SMRs, that's the reason why SMRs take so long. I mean, I've heard differences between 30 minutes to over an hour. And I did one this morning, and honestly, you just start digging and you find out more and more stuff about that patient's ideas, beliefs, expectations, family environment. And this is where, from a sort of like a multidisciplinary team, we can start utilizing the professions that we can use in the PCN. So you can then start saying, okay, don't worry, I've got a social prescriber to help you with that. Okay, we can get a paramedic to come and have a look at that infection that you're talking about, or look at your leg, and it's just the opportunity to utilize these teams as part of the structured medication review is just enormous. And just a quick word, there are obviously two types of SMRs. One is a proactive type of SMR where you might be thinking, right, let's see who are on 10 or more medications, who is on opioids, care home residents, and so proactively looking for those individuals at highest risk because of their medicines that could increase the risk of them being hospitalized. And on the flip side of that, obviously, then you got your reactive ones, which reactive means an incident has taken place where the patient has had to go into a hospital or has had a fall. So you're responding to an event which could be medication related. And remember, our fantastic community pharmacists can also refer patients to us in order to do structured medication reviews as well. So it could be identified as a result of another healthcare professional within the PCN, but also outside the PCN to help look at that patient's therapy.
It's a really good point on community pharmacy, actually, and I think having held beliefs that actually community pharmacy could and should play a bigger role in primary care, I think a lot of the PCN work presents the perfect opportunity to really strengthen relationships with your community pharmacies in the area, and I'm sure that's something that is close to home for you as well, being a community pharmacy owner. So yeah, that's a really good point. For me, an SMR, I probably in the old days would have viewed a really good med review as an SMR. That was kind of it really for me. But yeah, I guess so, you know, some of the SMRs that we carry out, as you say, are kind of such a long invested process versus others. You know, we in our PCN might pick a phone up to a patient, run through things. It does happen. Absolutely everything's fine. An SMR could be a 10 or 15-minute chat in theory, but I would say, you know, for every one of those you probably get something else that is a everywhere you look there's a problem sort of thing. So I think part of it, just to say on the SMR piece, it's different in all areas, and it has to be what you're comfortable with as a clinician. But I don't often like having an appointment list and being too prescriptive about the way that we do these things. I like being quite fluid in the approach, really, and almost having a list of patients that we can then work through. That's how it works for us anyway. Linking to that point, we've got a question around how we plan our days in practice, and can we talk through a typical day? I'll sort of kick off and just say that my typical day probably is a list of tasks that I get from our team on all manner of things, that discharge letters that have questions on that our script team can't answer, things that would generally go to the GP, essentially that involve medication or changes to medication. So I generally work through that on a daily basis, knock that list down a little bit if you like, and then sort of move into my recalls, bloods, proactive SMR list. And having this central list, as I say, it's been a real helpful thing for me, because we've been able to not only triage with other people in the practice, like Darshan says, if you've got a COPD patient that's quite complex that you maybe don't feel comfy with, if you've got somebody needing spirometry and you're not comfy doing it, or you've actually got you know, an advanced type 2 diabetes patient who you're just not sort of okay to mess around with their medications, you can still add value to those patients and you can still capture the problems. You just then triage for the solution, really. That's the way I would view it. So I don't think it's competency related in all cases. What about you, Darshan? What does a typical day look like? Putting COVID vaccinations to one side, because I know that you spend an awful lot of, like a lot of people out there, an awful lot of time on that as well. But what does it look like?
So a typical day would be similar to, it would be to work through any tasks in the morning for maybe half an hour to 45 minutes. And it could be particular aspects of queries related to medication, looking at maybe discharge summaries for particular patients. I might have to even incorporate some of those tasks as part of my appointment list, where I might need to then intervene with the patient to follow it on, because a task is just an alert to say, these are the set of things that other professionals within the PCN or within the surgeries are asking me to look at. And then I might move on to look at, okay, I know you said about structured medication reviews not being too prescriptive and not having set appointments, but at the moment, I might be an outlier on that one. I appreciate that. I think that's very advanced for you and very, you know, your foresight, actually, that's awesome. That's how I think it should be. But I think for my stage, I feel a bit more comfortable when I've got a beginning and an end, whereas I feel otherwise I might just keep on doing it, and the value that then I'll be demonstrating just for that one person might be diluted by the time that I've spent unnecessarily. Okay. So I prefer right now distinct times, but hope to get to your stage at some point, Ryan. But I don't think there's a right or wrong way in many ways. It's what you're comfy with, isn't it? Well, this is it. Yeah. Finally, I would say maybe medicines reconciliation, looking at drug alerts, doing any particular audits. So recently, we done one on quetiapine that apparently the prescribers are writing up modified release versions as IR and IR as modified release. So just trying to tidy that up because of the risk associated with the patient. And then maybe looking at, sort of quality improvement projects, which as part of the pathway which I'm on and what all PCN pharmacists would be on, trying to look at how can we optimize patient care utilizing the skill set that we've got within the PCN and the practices. And finally, I mean, like, I'm not an IP at the moment, but I'm hoping to become an IP. And one of the areas that have been identified within the practices that I work for within the PCN is diabetes. That's one of the biggest heavy hitters. And I saw very briefly a person asked, how do you decide to start focusing on particular aspects of clinical activity? And you just look at what the biggest issues are within that PCN. When I first applied, I looked at, it was then called NHS Choices, but now it's just called NHS. So you're looking at what the prevalence of particular conditions are. So the highest prevalence I had in my PCN was diabetes, cancer, respiratory, and mental health. So I could tell that these were the biggest issues for that cohort of people, the demographics that I'm going to serve. So this is where I really need to start focusing and hence hopefully showing value.
Yeah, absolutely. That's a really important point. Some of the questions in the comments we're getting in, we've got quite a few coming in. I know we've only got 10 minutes left, so I hope we get a chance to answer as many of them as we can. The first one, just really quickly to cover this off, how did you apply to be a PCN pharmacist, and is there any further training required one needs to undertake beforehand? So the answer to that one, really, I would say, for the first and foremost, is probably NHS jobs is going to be your primary source of roles that are out there. By all means, speak to people in your own network, speak to people who are already PCN pharmacists, get a good understanding before interview. But yeah, that's where you're going to find it. In terms of the further training, we've taken pharmacists from community, from hospital, from all over the place. The whole point of the pathway really is to get everyone to a level at the end of it. So the training is provided as part of the role, and there is an element of training time within the role as well. So I think it's important to be mindful of that when coming in. We've got a comment and a question. The observation is that holistic wellness approaches and health coaching are skills that are largely absent in typical pharmacy education. I would agree with that, actually. I think we are very, I think we're very almost blind to that at times. Can you comment about how the average pharmacist can build these post-registration? So how would you build health coaching skills? I mean, for me, it's a bit of an unmet need. Yeah. In our practice, well, in the life of any practice pharmacist, I would say that your ability to coach somebody, rather than it being something that's taught through university, is potentially something that you develop as a person. How are you in terms of speaking to people? How are your consultation skills? You could pick the phone up and explain cholesterol levels to a patient, and through that explanation of their cholesterol, they put that link together, if they've seen a reduction, with the fact that they were out walking more in the last year. It's quite a powerful thing when you talk through. If I'm going to call a patient, I don't know about you, Darshan, but I'll say, we've just done your bloods, we're going to have a chat about your meds, let's kind of just review your bloods. And the number of patients who come back to me and say, all right, okay, so what should that target be, and why should it be that? All right, okay, so it has come down. And actually just giving them that knowledge is quite a powerful thing. I don't know what the answer is hand on heart in terms of health coaching. I don't know whether you've got a view on that, but I think that's a little bit of a blind spot still.
Absolutely. And I honestly, it's the most important and impactful soft sort of skills training that as pharmacists and pharmacy teams we need to acquire, because you could be clinically the best person in the world, but if you can't communicate effectively, and if you can't get the patient to be responsible for their health, then it'll almost be like a parent-child relationship where you're feeding them information and medicine, and they're not taking responsibility. It needs to be an adult-to-adult conversation where you're imparting data and getting them to be responsible for their own health outcomes. And once you got that, half the battle is won.
Yeah, agreed. Agreed. I think that's a really powerful thing if you can unlock that in a patient. So again, covering some of the questions, some of them might be quite quick ones actually.
Yeah.
How long should a PCN pharmacist have for an SMR? Honestly, I've seen various models. I know that there isn't a target at the moment.
Yeah.
I think 30 minutes is not an unreasonable, 20-30 minutes is not an unreasonable average. I've heard from pharmacists who've had 10 minutes and have been absolutely flogged to death trying to finish a ledger of 10-minute SMRs. Not a good way to go. Equally, I've seen some really low targets at CCG level as well. I honestly think it's an individual thing that you just find yourself and you need to get comfortable with. But if you're anywhere around 30 minutes as an average appointment, I would class that as a safe environment to start out in.
Yeah.
And see where you get to really. A couple of other questions. Should all clinical pharmacists be prepared to become advanced practitioners to remain in PCNs? Honestly, I've worked with lots of practice pharmacists who some of the most experienced people that I know and some of the most highly respected, and they're not actually IPs. So whilst that might not be a sensible thing from a career perspective to future-proof and protect yourself, I don't necessarily know that any level of qualification should be forced on a person. I'd probably see it as you find your own role. It's an individual thing. For anyone that wants to be an ACP, happy days, go for it. Anyone that's kind of happy being a non-ACP, so be it. That's okay. I don't think you have to be an ACP to add value is probably what I would say.
No, but I think you'd want it as part of your career progression, because I think that's what PCN is all about.
Yeah.
You know, I mean, if I tell you very quickly, my personal objective for the next 4 or 5 years is to complete my pathway, get my IP done, become an ACP, and one day I want to become a partner in the GP practice. I want to actually be a partner in the GP. And I've seen partners, pharmacist partners who are currently there. And why not have high aspirations, but show value, contribute towards the workload, have something to offer. And I believe ACP is one of the pathways in which you can do it. This is my belief.
Yeah, absolutely. I agree. And for the motivated pharmacists out there who want to pick that up, all the best with it. And I think it's a good thing. It's all about adding value. I think sometimes it's easy to get caught up with the titles. I've seen IPs and ACPs who've added less value than non-prescribers. Because it's about how you put yourself out there in the practice and what you do. That would be my view. That's clearly a generalization, to extend it to say all ACPs are no good. That's not what I'm saying. No. But definitely, I don't think the label determines what you do. No. Right, a couple of questions then. We've only got a few minutes left, and I think it would be nice to summarize. But do we have much interaction with secondary care? Personally, me, not at the moment. Darshan, yes, no?
Not at the moment, not as much as I'd like to.
COVID might change things potentially if assuming things settle. How would you prevent overlap between diabetes nurse specialists? Our DSNs and actually the diabetes nurses in the practice, they come at things from a slightly different angle to us pharmacists. I don't think there's any overlap because we've got such a swell of diabetes patients. We haven't got any time to manage these people. So for me, I don't think there's any risk of overlap. It's more about how we contribute in a meaningful way.
And maybe just to add on to that, we have got a diabetes academy as well on the MORPh platform. So it's worthwhile just checking it out as part of like with the offerings to develop yourself to the place that you want to be able to do with the support and care that you'd get.
Yeah, absolutely. Question, does CPP completely prepare you for real world of PCN pharmacy? My answer would be no. I think it's just as important about kind of throwing yourself into the team, on the job training, getting to know the people in the team, and building up that good rapport, really. One for you, Darshan. How do you manage the clinical admin expectations that are placed upon you?
You set your own agenda, you set your own time. And by virtue of speaking to the reception and the admin team, and also your clinical supervisor, you're able to set what you do within the time frame you can do it. So you're not bombarded. And this is all about relationship building. It's about me knowing the individuals within your team so that they can impact well on your role and get the best out of you rather than bombarding you.
Yeah, yeah. The question linked to the admin is asking kind of almost, I think, is there a right and wrong in terms of expectation of clinical admin as well? The way I would put it is, to be honest, don't be afraid to say when you feel like you're not adding enough value and the process is holding you back. If you feel like you're spending a lot of time with simple discharge letters that are kind of a waste of your clinical experience, don't be shy about it. Put your hand up and say so. We've got another question about PCN Pharmacy and linking it to IP training, asking why you chose PCN Pharmacy before becoming an IP. I think it's probably fair to say, Darshan, because the IP is built into the pathway over the 18 months, at least it comes as a package, basically, the IP. That was presumably your thought process, was it?
So no, IP is separate to the actual pathway, but it can be incorporated into the pathway separately. But I wanted to upskill myself clinically, become more, because once I become an IP, I can guarantee you, and many IPs out there will say, the pressure that is then thrusted upon you by the GP team is a bit immense to start prescribing or start signing things off. Let's build up the competence, let's build up the confidence, utilize the training and education we've got to get you there before you start becoming an IP. So give yourself that time.
Great. We've got very little time left. What I wanted to say, though, is jump on our website, join our Telegram groups, join the PCN Telegram group that Darshan's part of. Any questions, feel free to reach out to Darshan and I. We're both reasonably nice people, and we're both happy to chat to you. Both active on LinkedIn. Darshan's got more friends than I have, but I don't hold it against him. It's been a pleasure to be with everyone today, and thank you all for joining us.
Thank you all. Thank you again.
Okay, welcome everyone to today's session. My name is Ryan Smith. I'm a PCN pharmacist and director of MORPh. I'm joined today by my colleague Darshan.